VMTVMAERM differences and its management.
A warm good evening to everyone. For the next few minutes, I will be talking about vitreomacular interface disorders, and let's see what exactly these OCT pictures depict. So as we age, the vitreous slowly liquefies and shrinks and gradually separates from the retinal surface. This normal aging process is called PVD, or posterior vitreous detachment. Sometimes the vitreous gel adheres in an abnormally strong manner, and this tug-of-war between the fovea and the vitreous will cause foveal architectural distortion, causing vitreomacular traction. Often it releases by itself, returning to its normalcy. Sometimes the undue stress can create a full thickness macular hole. So this is the same story shown in OCT. The posterior vitreous cortex and the retinal internal limiting membrane are bound at their interface by certain macromolecular attachment complex. So the posterior vitreous detachment usually begins in the perifoveal macula, later on completely separating from the macula as well as the optic disc. So when it completely detaches from the optic nerve head, it is visible as a V-string. So PVD is a normal aging process. Problems occurs only if there is an abnormal adhesion between the vitreous and the internal limiting membrane. It can lead to vitreomacular adhesion, that means there is only attachment but the layers are entirely normal. Or when it changes the foveal architecture, we call it as vitreomacular traction, or it can open up leading to full thickness macular hole, or it can lead to a proliferation on the retinal surface leading to epiretinal membrane. The International Vitreomacular Traction Study, or the IVTS group, was convened to develop an OCT-based anatomical classification of these vitreomacular interface diseases. So they have clearly defined vitreomacular adhesion as a persistent vitreous attachment to the macula within a 3 mm radius, attaching in an acute angle. But the important thing is that there should be absence of changes in the foveal contour or retinal morphology. At this time, the symptoms will be, usually the patient will be asymptomatic. Vitreomacular traction, the same, the persistent vitreous attachment within a 3 mm radius, but there will be changes in the foveal contour, retinal morphology in the presence of foveal pseudocyst, intraretinal elevation of fovea, retinal capillary leakage or macular schisis. At this stage, the patient may have reduced or distorted vision. So they call it as a focal attachment if the width of the attachment is less than 1500, and if it is more than 1500 they call it as broad, and if the attachment is associated with any other macular abnormality such as AMD, RVO, DME, they call it as concurrent. An epiretinal membrane can be defined as a pre-retinal proliferation of myofibroblastic cell. PVD is very important in the development of epiretinal membrane. It has been documented that about 90% of the eyes with ERM may have an associated PVD. So what happens during PVD is that there can be micro breaks in the internal limiting membrane. So through these micro breaks, glial cells, hyalocytes can proliferate, and later on they can develop contractile properties causing wrinkling of the retinal surface. So in 2017, Gavetto et al. Proposed a 4-stage SDOCT ERM classification. So the stage 1 means that ERM is present but the foveal pit is present and the well-defined retinal layers are there. There is no change in the foveal contour as such. In the stage 2, the foveal contour is lost, that is absence of the foveal pit, but still the retinal layers can be defined. In stage 3, there will be the presence of ectopic inner foveal layers or IFL, which I will discuss. And in the stage 4, there is IFL with the presence of disrupted retinal layers. So in this, you can clearly see the inner nuclear layer and the inner plexiform layer, they do not cross over the fovea. But in stage 3, IFL or the ectopic inner foveal layers, this inner nuclear layer and the inner plexiform layer continuously grows across the fovea. Why this is important? Because the development of IFL was accompanied by a significant drop in visual acuity. So this is two pictures that shows the degenerative lamellar, the lamellar macular hole. So lamellar macular hole can be either degenerative or tractional. In the degenerative type, it shows a top hat appearance. All the layers are almost affected. there will be ellipsoids on defect, so the visual acuity will be usually poor, and this is associated with a lamellar hole associated epiretinal proliferation or LHEP. The other type of lamellar macular hole is tractional lamellar macular hole, usually which is associated with epiretinal membrane, and this causes a sharp edge split at the outer plexiform layer. Usually the ellipsoid will be intact and the visual acuity will be relatively good. So this is the pseudo hole appearance which is seen with the epiretinal membrane. So this is called as pseudo hole because no loss of retinal tissue is there, only the clinical appearance of the hole may be there. So there will be invaginated or heaped foveal edges with a concurrent ERM with a central opening. So coming to the management, the current mainstay of treatment is like watchful waiting or surgery. Vitreomacular adhesion can be considered as a normal stage in the natural history of posterior vitreous detachment. So the first approach is to re-examine the patients using an OCT at a period of 3 months. Even in cases of vitreomacular traction, observation still remains an option given the possibility of spontaneous resolution of VMT. But during this interval, the patient should be advised to perform periodic self-examinations of monocular reading or Amsler grid can be given. So intervention can be considered when the patient is symptomatic, that is with metamorphopsia or blurred vision, or there is persistence of VMT causing distorted vision. So the current options are pharmacological vitreolysis of ochriplasmin or a standard vitrectomy. So coming to the pharmacological vitreolysis with ochriplasmin, the vitreoretinal interface, it is consisting of so many extracellular matrix proteins such as laminin, fibronectin and collagen. So ochriplasmin, it is a recombinant truncated form of human plasmin that has proteolytic activities against this protein. These attach to these proteins and lyse them and causing a natural or enhances the posterior vitreous detachment. Theoretically, it stood good and the safety and efficacy of ochriplasmin were announced with MIVI Trust and OASIS study, but there were adverse effects like transient vision loss, transient changes in the ERG and the OCT. The cost also being a major back factor, and now the improved vitrectomy technology has lowered the surgical morbidity and more rapid patient recovery, so this is mostly obsoleted. So surgical intervention in VMT, surgical release of the vitreomacular traction and resolution of the anteroposterior and tangential traction by vitrectomy is the routine. So during surgery, it is very important to create a discontinuity in the posterior vitreous all around the fovea. That is, we have to isolate the vitreomacular traction from the surrounding vitreous. That is, usually in PVD we start from the optic nerve head section, but in this case if we do that, this can open up to a full thickness macular hole. So this technique will reduces the risk of causing an iatrogenic macular hole during surgery. So in ERM, the optimal timing of surgery is still a debatable topic. So the optimal timing to prevent irreversible damage is currently unknown. However, this may be prior to the development of an ectopic inner foveal layer seen on OCT. So the aim of the surgery is to remove the membrane and release the retinal traction. So standard pars plana vitrectomy is the degree of the choice. The degree of vitreous clearance is surgeon dependent. Sometimes the ERM can come as like what we do capsulorhexis, it can come as a maculorhexis very easily, but sometimes it may be difficult. So chromovitrectomy and the staining of the ERM usually helps. So in usually the PVD will be present at the start of the surgery in most of the cases, but in some cases there will be posterior hyaloid will be attached. And in these cases, we should be extra careful. The removal should be as dramatic as possible. There will be some kind of ILM attachments throughout the vitreous. So always you can do multiple times of staining, removal, do the peeling as much as possible. And whether to double peel, that is whether to take the ILM along with the ERM is also a debatable topic. So what the pros are that it enhances the complete removal of the epiretinal membrane and the rate of recurrence of ERM is significantly less with the double peeling. But what they say is that the peeling of ILM, it is associated with inner retinal dimpling, greater microscotomas, and even if you peel the ILM or do not peel the ILM, it does not appear to improve the visual acuity outcome. For this reason, some authors will do double peeling only for recurrent ERMs. So even after ERM in grade 4 surgery, grade 4 ERM surgery, standard is a 2-letter improvement, but even in the absence of an improvement of visual acuity, some patients have reported relief from metamorphopsia. And the post-operative visual acuity will improve gradually. Do not expect a miracle post-operatively. It can usually happens between 6 months to up to a period of 3 years. So ERM and VMT, it does not demand emergency surgery. An initial period of observation makes sense in early cases of ERM and VMT. And not that you are not treating the OCT, you are treating the patient. So visual acuity alone should not be the criteria in deciding the surgery. Primary importance should be given to patient's visual need. Although a great topic of debate, surgical intervention can be considered earlier to provide a better final visual acuity, nice with ERM and VMT. Thank you.
Nice videos. Any specific?
In all these ERM cases, PVD will be there. All macular mode cases, there won't be any PVD. So this is the standard. So I leave tripod. If tripod is sticking around, I leave it. That is steroid. VMT is a what is that? Anatomical abnormality. IVTA will not reduce unless it induces some PVD. But for that you put
For his